nobody will tell you about. And I think these things are really crucial. So the very first thing I want to tell you is, especially if you do trauma surgery, when you see the patient, you examined the patient, what is the next step? So now you have a diagnosis in your head. What do you do next? I don't want to hear anybody denying it. So I've come forward.
Take a thorough history?
No, you're done. You have history, you have a rough idea about the condition of the eye because you're done with all the preoperative examination and tests. What comes next?
Is there any intraocular foreign body?
It's a good question, but it's too specific. I want a more general answer.
Plan.
No, like that.
Please stand up, turn around, and say it loud.
First need to make a plan.
Loud.
We do. We need to
Plan. Okay, thank you. That's exactly what you need to do. You do not just do what a lot of surgeons do, which is you sit down and say, let's see what I can fix. That's not a plan. The plan means, again, you have a rough idea where you are. You have a rough idea where you think you will be at the end of the surgery. Planning means, how do I get from here to there? Exactly the same as driving a car in a city. You don't just start driving and hope that you will get somewhere. You have a map, you have a GPS, something. And just like driving, your plan will be modified because of the findings, which may be somewhat different from what you thought there would be, or because the tissues react differently from what you expect. So, rule number one is plan. What is rule number two? Even they don't know. Rule number two is control. What is control? Control means that whatever happens inside the eye during surgery happened because you wanted it to happen. And nothing will happen that you did not want to happen. That's the ideal situation. Of course, it doesn't always happen, but that should be your goal. So plan, control. Number three. You already heard this before. Number three is why. What is why? You have to know everything that you do, why you did it. So, just to give you an example, you have to know why you want the surgery to be done early or delayed. That's strategy, the big question. What kind of surgery you do? That's another strategy level question. But then during surgery, you have tactical questions. Let's imagine there is a membrane. You have to decide when to cut that membrane, how to cut that membrane, which means what kind of scissors you are going to use, what hand you will have the scissor in, when do you do it during surgery, at the beginning or you delay it? Are you going to cut it in the middle or more towards the retina, etc.? These are tactical questions. So when somebody comes to my operating room, I will tell them, first, there is no stupid question. Because I often hear this, I have a very stupid question, and my answer is there is no stupid question. There is a stupid person who doesn't ask the question when the question arises in the brain. And it's true here as well. You have to know why you do what you do. And when you are in my operating room and I tell you to ask me any question you have, and you say, so why did you do that? And if I do not have an answer to that, that's a serious problem. Because I have to explain why I did what I did. Part of it is to question not only what happens in surgery, but also question dogmas. What is a dogma? Dogma is something that people older than you will tell you because this is how it was always done. One example from the previous talk, you could see that if you have a foreign body in a similar injury, the rate of endophthalmitis is higher. So for that reason, when I was learning ophthalmology, they said you have to take out the foreign body immediately. So you come in with a foreign body injury and you are at higher risk of endophthalmitis. So you come to the operating room, I take out the foreign body. Or not. And if not, which is obviously the answer, why not? Why do we not solve the problem by taking out the foreign body? Yes, we could do more damage, true, but I'm talking about the endophthalmitis risk. Because once the foreign body enters the eye, the bacteria are already there. If you take out the foreign body, you are not going to change the risk of endophthalmitis. So taking out the foreign body is not going to solve the problem. Taking out the medium that might have been infected by the foreign body, that is what helps solving the problem. Okay? That's just one of the many dogmas that you hear. Okay? Last word about starting surgery. You are going to sit down and work on eyes here. When you sit down, it may not be true here because the instrumentation, the equipment different from what you will do in your real life. But what is the first thing you do?
Getting used to the machines.
Getting good. It's a good answer, but that's not what I was looking for, but it's a good answer. This is something that young people don't think about until they get older. And by then it's too late.
Posture.
Hmm?
Posture.
Exactly. What young people do is when you sit down, and probably the microscope is not at the right level, the chair you're sitting on is not the right height. So what do young people do? They adjust to the position, whatever they find. Don't do that.
They are eager to operate and not sit properly.
Their focus is somewhere else. And when you're young, you can easily adapt your posture to the position the operating table, etc. is in. But after a few years, what will you have? Terrible back pain
Yeah.
and terrible neck pain.
Yes.
Believe me, that's what's going to happen.
55% are published
Yes.
having problems.
It's a tremendous problem, but you will not recognize it until you have it yourself. So don't do that. When you sit down, you have to have the chair adjusted to your position, what is comfortable, and then you adjust the microscope and the operating table accordingly. If you don't do that, eventually you will pay more attention to your pains than to the patient. Any questions so far? Okay.
Only addition is to do exercise to keep the back and front strong.
Yes, it's very important to exercise, but if you don't take the proper posture exercise will not solve the problem.
Yes.
It will delay the symptoms. Okay, no question. Okay, very briefly, I will talk about Earthly is in the way. Can you see the slides? Let me move here. That's okay. So, I realized about 35 plus years ago that we have an issue with how we call different injuries. And this issue was present in presentations, in publications, etc. So let me give you a few examples. You see blunt trauma on both sides. These are obviously two articles. They are talking about the same diagnosis. Blunt to this, let's keep on playing. And our air is gone. We have a picture. Where is the picture? Oh, here. So what is amazing about this is the one who is not in medicine. So when you talk to the patient and you explain what the options are, etc., when the patient, after all your explanation, will ask you a question, which is, what would you do? It's your eye. What do you answer to that question? There is only one good answer. The answer is, I don't know. You think you know, but in reality, you don't know. Because when you are the patient, your mindset completely changes. So in this case, I'm going to finish with this sentence. This guy who wanted to die, now, for a while, he was blind in both eyes. At that moment, he really wanted to live. That completely changed his thought process, his approach to the world, etc. So keep that in mind when you see patients with terrible injuries, that you're not treating an eyeball, you're not treating retina, you're treating the person who has a problem. That has to be in your mind the whole time, okay?
Willst du was sagen dazu, Wolfgang? Du hast ja von
Ja, also die Strategie ist ja dann hier über die Parazenthese, die breit genug angelegt sein sollte. Also wir sollten möglichst in beiden Richtungen da einstecken. Dann durch das durchzugehen, hier am Ende und dann hier auszufädeln. Wir sehen, dass die Drahtnadel in der Mitte etwas gebogen hat. Dann kommt man da leichter wieder raus. Wenn sie ganz gerade ist, dann tut es schwer, da wieder auszufädeln. Und jetzt kommt dann die zweite Nadel. Ganz wichtig ist, da habe ich mich auch manchmal verhaspelt, wenn Sie dann mit der zweiten Nadel durch die Parazenthese durchgehen, dann machen Sie so eine ganz leichte Gleitbewegung.